One thing that we do that most people don't is there's a high amount of children that will be referred to us as ADHD, and they're
Mhm.
not. They're not ADHD. They have
Mm.
a high trauma score,
Wow.
and
Wow.
trauma trumps ADHD every time.
Our special guests for today are Dr. Rebecca Wright, DBH, LBA, BCBA, QBA, who's the CEO of Right Care LLC of New York. We also have Dr. Allison Earl, DBH, LPCS, Chief Clinical Officer, Clinical Director at Hands to Guide You in Oklahoma City, Oklahoma. Thank you, Dr. Wright and Dr. Earl, for joining us today.
It's a
Thank
pleasure
you for
being
having
here.
us.
Great. We're going to just dive right into the questions from our audience. The first question we had was, can you tell us a little bit about your background and how you became involved in addressing youth mental health challenges within the field of integrated healthcare?
Before I was in integrated healthcare, before I was in healthcare at all, I was actually a special education teacher. So I received my
Oh,
bachelor's degree in behavioral health and then decided that I wanted to do something different. So I went and got my master's, and I had like 4 classes left before I was completed with my LPC. I ended up moving to Texas and doing an alternative certification program.
hmm.
And that's actually where I began learning because I worked in a specialized autism school, and
Oh,
it was a senior high school. So we only worked with 11th and 12th graders and up. In
hmm.
most states, special education students are allowed to stay in school until they're 21, sometimes
Okay.
22, depending on where their birthday lands. So I worked with that population. I worked with mid-level functioning, autism, some other developmental disabilities such as Down syndrome. I've had students with Rett syndrome. So I
Hmm.
found that whenever I was setting as a teacher, there were a lot of times whenever I wasn't seen as the expert, even though I was the expert,
Mm.
or what
Okay.
was going on in the
Okay.
classroom,
Hmm.
whether that was from administration, other teachers, or even parents at times. So I decided that the best way to do that would be to become an LPC. And then I was the expert in the room whenever those children needed to come see me in a different setting.
Hmm.
So that's really what I saw the challenges where those children weren't getting any mental health help. The parents didn't have a lot of respite help. They didn't have a lot of BCBA help. And I know
Mm.
Dr. Wright can speak to that in her area. I'm sure it's very similar across the states. So I found that if I was able to be the expert in the room and help the parents, then I was better able to serve those children
Hmm.
and those young adults who were starting to progress, but still weren't really getting any mental health challenges needs met.
Oh,
So
okay.
that's really where I started. And then after I got my DBH, I ended up really digging in and I became a certified clinical specialist for autism. And so that's one of my specialties
Mm.
as a clinician at Hands to Guide You.
Outstanding. Outstanding.
Wow, I really enjoyed hearing your story, Dr. Earl. So we're definitely in the same page. And
Right.
so my journey started with the youth mental health when my brother unfortunately was misdiagnosed as a young child, when in
Mm.
actuality he was misdiagnosed with another disorder,
Mm.
and
Oh.
very unfortunate. And he was really autistic at the time. So from there, working with my brother as a sibling with someone with special needs, I went into school psychology. Well, I went into psychology first, not knowing that my mother, prior to me, studied it. She did not tell me. She did not want to
Okay.
influence my decisions. And I found out
Oh,
later that she
okay.
also studied psychology.
Oh, okay.
And I went for the undergrad in psychology. Then I went into school psychology because the clinical track was pretty hard and tough in the city of New York. New York City is pretty tough.
Hmm.
They have a couple of schools that are well known for clinical psychology, and I just couldn't find my way. But someone told me about school psychology, where we did have to talk a little bit about the clinical aspect of the psychology, but it was more
Hmm.
of the educational piece. How does a child learn?
Okay.
I did that. I took my classes. I took a break, and then I became involved working with the state of New York, working as a behavior specialist. Although they called us a psychologist, we had an exemption because of that particular, it was the Office of People with Developmental Disabilities. It's state-run, different agencies provided services with individuals who had all kinds of disabilities, intellectual disabilities, predominantly, but they also had other disorders. I worked with the kids, I worked with the teenagers, I worked with the males, men, grown men, I worked with grown women in the group homes. And from there, I went and got my BCBA, which is Board Certified Behavior Analysis. Then I became a licensed because it's required by the state of New York to now be licensed. So it's a licensed behavior analyst. Then I became a QBA, which is a qualified behavior analysis analyst. So I just went in that direction. And I worked with Medicaid, private insurance within homes, clinics, schools. And then I realized I felt stuck. And another colleague of mine introduced me to the DBH program. And I said, you know what, I have a heart for advocacy for special needs population. Maybe if I go into this direction, maybe I can get more done for the population. So that was my story in a nutshell.
Outstanding. Both of you have some very, courageous approaches, grassroots. You really put the work in, been in the trenches. On the pathway of gaining your DBH. And I have to commend that because we have similar backgrounds with the hands-on direct work with people. So outstanding. Our next question, what has been your journey in addressing youth mental health within other healthcare disciplines? You spoke about some things that motivated you, but let's zero in a little bit more on that part. What motivated you to pursue the path a little bit deeper?
One thing that really motivated me, I did want to do a BCBA, so that's also another place that Dr. Wright and I connect. Before I finished my LPC, I really wanted to do a BCBA because that's where my heart was at that time. But whenever I started working with Hands to Guide You 6 years ago, actually today is my 6-year work anniversary.
All right, well, happy work anniversary.
Congratulations.
Yeah, thank you. But 6 years ago, we were working more in the schools in the Oklahoma City area. We worked with a lot more of the lower income schools, and it was less about the developmental disability piece and more about those kids that their needs weren't being met in their home or in the classroom or in extracurriculars. There were a lot of gaps in care. And my mentor is a DBH as well. And so whenever we were working in the schools, we just found that there weren't a lot of ways that we could meet their needs without us physically being in the building. And that's one of the things that Oklahoma does is at times they will place a large agency. They'll put a couple LPCs in the actual school so that those kids have someone to go to outside of just a school counselor. But we found that wasn't really our path. That wasn't something that we wanted to necessarily pursue because we're able to meet the needs at a higher level whenever they can come to the clinic versus seeing them in that setting. So that's really where we started integrating more rather than being in the school setting.
Gotcha.
We started really pulling them to come to the clinic for outpatient.
Makes
because
sense.
We found that we have had better quality care, higher outcomes, all of those things have improved rather than giving our time in the school setting for an hour or two here and there. We can now schedule those kids and see them weekly. And that makes much more of a difference because we can also schedule time with their parents.
Outstanding.
That's awesome. So I definitely can relate. My journey, I always joke that my journey is still beginning, even because I just graduated with a DBH. Although I had experience working with individuals with special needs within the schools and so forth, and the youth. I think I was very restricted on what I could do. So getting the DBH, I believe, in my opinion, is my start of my journey towards the youth mental health to really get into the trenches, even though I was kind of partially in it. It was also much that I could do. But I will say that in my journey, I've realized that there are not enough integrated healthcare assessments for the youth, although there are some in my research that I've noticed, but they mostly deal with the medical aspect of the child, not necessarily medical and mental aspect of the child in my research. So that's one thing I discovered in my journey. But I will say what has inspired me to push forward into youth mental health is the exposure to the classes that I've taken as a DBH student, such as one class was called Integrated Healthcare and Autism. And the other class was called, I believe it was Trauma Informed Care, where they talked about the ACEs, which I have never heard, which is the Adversive Childhood Experiences screening tool. Had no idea it exists. So when I got exposed to these classes, it has pushed me further into this journey and has inspired me more to get more involved.
Outstanding, outstanding. Our next question, how have you incorporated and prioritized youth mental health into integrated care models, and how has this impacted patient outcomes?
That's actually a perfect segue from what Dr. Wright was just saying, because I also am a trauma-informed clinician based in the study that I did at the DBH program. But I was lucky enough to learn about ACEs before I went into the program. One thing that our clinic does is we send out screening tools with all of our intake paperwork. So every patient that walks into our office as a scheduled patient must complete a P9, which is the depression screening, the gold standard depression screening. They also complete the gold standard anxiety screening. They also complete a post-traumatic stress disorder screening and their ACE.
Okay.
And so we have an ACE for adults, and then we do the ACE-Q for the children. So the way that we've really incorporated and prioritized the youth is knowing their ACE score before they come in. But then we also ask their parents about theirs because of that intergenerational trauma piece. And oftentimes, whenever those children are experiencing those adverse life experiences, it's usually because the parents don't know any better because of what they experienced.
Gotcha.
So by giving them an integrated care model and showing them how we can connect less physical health complications with better mental health care, it's really allowed us to see those children thrive more in all of their other environments, while also helping those parents learn increased parenting skills, really to not parent out of guilt or grief, and how to be an upstanding citizen to show their children what that can look like.
Right.
We do have quite a few kids that we see that are in the justice system and having to go to court and things like that. So that's another way that we really integrate that care, is we just make sure that we have a well-rounded approach to treating not just the child, but the whole family as a unit. And in the event that the child needs more specialized care, we then offer that.
Outstanding, outstanding. Thank you for sharing that. Thank you. What are some of the biggest challenges you have seen faced in addressing youth mental health in traditional healthcare settings, and how did you overcome them?
You want me to go first, Dr. Earl? Okay, I'll go first. What I will say is this. I don't necessarily work in the traditional healthcare setting, but I will say that I've worked in the homes. And in the settings of the homes, I found that there is a challenge when it comes to the level of cooperation of the caretaker. So in that sense, it's a lot of interpersonal conflicts that I come across. For example, I may work with parents who are also, well, I'll start with saying there's still a stigma about mental health challenges.
Absolutely.
And so with dealing with the parents, some of my parents are neurodivergent themselves. And some of them are aware of their mental status. Some of them are not aware of their mental status. Those who are even aware of their mental status might be in denial of their child's mental status. So that causes a great challenge for me to provide a good quality level of care in most cases. Now, how did I dealt with the challenges? is that I would first say through health literacy, which is usually I address it in the sense of parent training or parent coaching, because what I've learned over time is that a youth will take on the attitudes, the beliefs, and the values of the caretaker. So if I can't get the caretaker to buy into the therapy, that it's effective and it's needed, then most likely the patient or the child or the youth is going to be resistant because they're copying the caretaker. The other thing would be cultural competency, where I get to understand why is there stigma in this family? Where does it come from? And then lastly is building trust, which is usually done by showing some type of level of empathy for the family. So I think that those are the things that would actually help to deal with the challenges, the interpersonal challenges that I've faced within the home.
Wow, outstanding, outstanding.
Yeah, it's so interesting to see the different paths that we can take while also being able to help a very similar population.
Right.
We house right across the street from one of the largest hospitals in our area. And so one thing that we see a lot of are those frequent flyers that go into the emergency room, mostly because of panic attacks or untreated mental health conditions. So we see that less with youth, but I can absolutely agree with Dr. Wright that it is going to start with the psychoeducation piece and really training those parents. There is a high level of denial with certain diagnoses. And then also that multicultural piece is very important. You know, culturally, there are some belief systems that just don't believe in mental health care, and they don't believe in sharing their stories with anyone that isn't either looking like them or in the same lifestyle that they live. And so rather than making them feel judged, one thing that we really adopt is what Dr. Nicholas Cummings taught, was doing something novel. And so if I can do something novel in the room with someone that doesn't look like me, they often become much more comfortable, and they often will share much more than what they were willing to do before. And then also, like you said, that level of empathy is really important, and really meeting them where they're at. So I'm not going to go in there and speak to them on a master's level or a doctorate level if they're not going to be able to receive what I'm saying. So really seeing where they're at and seeing who they are as a person based on what you know about them initially is, I have found, the best way to really integrate that care and change the interdisciplinary style in the event that that has to happen.
Okay. Thank you. Thank you. What innovative approaches or best practice have you or others implemented in addressing youth mental health challenges? And what results have you seen?
All right,
Go ahead, Dr. Wright.
All right. So, excuse me. There are two innovative approaches that I've been, now that I've graduated, have further time to deal, study deeper into. Both approaches are patient-led, and it really focuses, it's really patient-centered and patient-led type of therapy. So the first one would be motivational interviewing. And that is basically using internal motivation and allowing the patient to be the center of the decision-making. And while I was a DBH student, I did do a paper based on childhood obesity, in which children ages 12 to 13 were given this motivational interviewing. And they noticed that it was really effective in helping those children lose weight. So, I mean, when you think about it, what kid or teenager would give up the opportunity to be in charge of their own therapy, right?
Right.
And so, I mean, the biggest thing that I noticed with the youth is they want their autonomy. I mean, all humans do. And motivational interviewing is centered around empowerment and also my autonomy, and it's my choice and my decision. The second approach that a lot of people in my field of work have been looking into is ACT, which is acceptance commitment therapy, which again is patient-centered, patient-led, where we're really focusing on what they call psychological flexibility. So we are coaching as therapists, we are coaching the child to identify what they value, who and what they value, and what actions to take to gain access to, you know, whatever it is that they're looking for towards their value. And what I will say is that ACT has been very effective in some of the school systems. I wouldn't say in New York, but they're effective in different school systems, and it has gotten a really positive feedback that the child is the one that is really leading the therapy with the school staff. I lastly would like to say about that also is the psychological flexibility piece, is that they're able to gain, they're able to move forward towards their goals and values. They're moving away from things that hinder them from their goals and values.
Yeah, that's great.
And they're able to, the flexibility comes in part where the child may have negative thoughts, may have had trauma, may have internal pain, and like I said, trauma from the past. But despite that, the psychological flexibility piece is that they're able to still achieve their goals despite the fact that they have these other internal things going on. So I would say those two approaches have worked.
All right, outstanding.
Very good. That's interesting. I love that. I'm not as familiar with ACT, but I have heard really good things about it. One thing, as you were talking, it really made me think. I was like, what innovative thing are we doing with kids? And one thing that we do that most people don't is there's a high amount of children that will be referred to us as ADHD. And they're not. They're not ADHD. They have a high trauma score.
Wow.
And trauma trumps ADHD every time. And so we always have found that we utilize a biofeedback system that is specialized for children. It's specialized in teaching them self-regulation skills by playing a video game, and it's on a tablet. So that's really the something novel, because they can't believe they get to come to therapy and play video games. And then the other piece is that innovative piece that most people aren't going to put a kid on a tablet and expect their behavior to improve. But this is a specially designed tablet. It's got specially designed games that cause them to engage. And every time their heart rate goes up, they have to wear a heart rate monitor while they're playing. Every time their heart rate goes up, it goes what's called the red zone. They have to launch their gizmo, and then they have to utilize some type of self-regulation skill that they've chosen out of 5. So they can take deep breaths to get calm. They can follow a line by tracing it. I believe there's a like self-hug kind of thing. And do is they choose that, and then they have to utilize that skill until their heart rate is into the blue zone where their game will start again. So the game gets extremely difficult if it's in the red zone, and if they don't pause it, they'll lose or they'll die or whatever it is in the game. And so by pausing that, it allows them to calm down, which then decreases the difficulty of the game because now they're calm, and then they can continue playing the game. It is required to complete for 45 minutes per setting. And then the parents are actually able to watch their child on a different tablet. We set the parent up to be able to watch them play so they can see how many times they're getting dysregulated during the game, how quickly they're able to calm their body down, and then how many times they're having to do that throughout the 45-minute period. And we have seen huge changes in the way those children are able to self-regulate in other settings because they're learning those skills in a comfortable environment. So I would say that's really the main, taking trauma into account and then utilizing something outside of the box is really the way that we've been able to be innovative with the youth. We used to do some groups and stuff, but we just really didn't find that to be as effective. It ended up being more of a dramatical setting than really a therapeutic one. And so we found that this was going to be the better way to meet those kids' needs.
Wow. Some great innovative approaches to that the both of you have enlightened us on, and great best practices. So very insightful, very insightful. Our last question for you. What future innovations do you see in the promotion of youth mental health within healthcare? And how could this impact the healthcare industry?
No,
Well, I
Dr.
can-
Earl, your turn.
Okay. This is actually a perfect question for me because in Oklahoma, we recently switched over to managed care for the Medicaid population. And our clinic sees a high amount of Medicaid population, probably 80 to 90%. And one thing that we have found is that from this managed care piece, now the primary care physicians, the pediatricians, and the specialists are required by the state to complete screening tools that they were not required to complete before.
Wow.
And they are required to refer them to the outpatient therapeutic setting where they may have kind of held on to them and gate kept a little bit then, where now they're actually kind of forced into doing it now. And so that's one of the innovations that's come through is now they are being forced to screen, which we have been trying to get all of the primary care physicians and OBs that we work with to screen on the front end, but now they're required to. So that's been one. And then how is it going to impact the healthcare industry? Well, it's going to not only allow better, higher qualities of care from the beginning, it's also going to allow us to not have to do all of that research on the back end to figure out what we need to do on the front end.
Good point.
Because now they're sending them to us when they need to versus holding on to them for 6 or 8 months, that those behaviors becoming exacerbated. And now we're starting way behind the finish line than we would have been before. So that's really the main thing that I've noticed over the last 6 months or so. Just a huge change in that referral structure, that care coordination, and that ability for us to work as an interdisciplinary team versus kind of standing on our own and being like, please help us out by doing this. Now they have to. So it it's changed how many children we see in the clinic, but it's also changed the level of care that we have to provide.
Standing.
Yeah, I love that, Dr. Earl, because when you were talking, I could think about accountability and collaboration. Accountability and collaboration, that's what's needed in the healthcare system. And with that, I would add on to that to say that, some future innovations would include further policy development. And we have policy, and we have policy development, but we need further policy development. Based on what you were saying, that having to get the physicians to do what they were supposed to be doing, but they didn't feel like they needed to do it, So I'd say we need further research in the area of youth mental health. I believe I feel, as both of you do feel, that the policy development should really focus on more integrated healthcare reform. Also, I think that healthcare settings, traditional healthcare settings, should fund training for advocacy training of practitioners. So I'm really into right now community development. Now that I got my doctorate degree, it's like community development. I'm kind of having an interest in that now.
All right, here we go.
Right.
The next frontier.
Right.
That DBH will do that to you, though. Yeah.
Right. You start saying, wait a minute, you start gaining more interest in things. But I say that because I said to myself, what about the legislative piece? I'm thinking more government politics and going that direction now.
Right.
But there should be further advocacy training. A lot of practitioners want to fight for their patients, the youth that they're working with, and don't know anything about how to let their needs be heard. One thing I would say, if there was more policy development and more trainings in advocacy, I think that the number one thing we would see, obviously, would be an improvement in population health. Obviously, we would see a cost effectiveness in healthcare, but the question would be why? And I would say that we're being preventive. We're providing preventive care if we are focusing on the youth mental health, because those individuals become adults. So I think that once we do that, we'll see less healthcare crisis for adults, for these kids who, when they turn adults, less healthcare crisis. We see less suicide, less homicide, less drug and alcohol usage. So I think that's why it's important that youth mental health should be focused on in an integrated healthcare type of fashion, you know.
And, I would even add to that, just to bundle services in that policy change.
Mhm.
There's a lot of different areas of healthcare that if we could bundle services,
Right.
I look at that more from a postpartum lens, but with children, we could bundle that case management lens, that biofeedback lens, that mental health care, that preventative health care, the parenting. If all of this could be bundled together and for providers to be able to be billed on in one billing code versus 5, that would also expedite the way that we could not only provide healthcare, but it would also help the pay structure not be so disjointed when getting, compensated for those services that we already are providing, but
Right.
there's just not a CPT code for.
Mhm.
So our policy change, absolutely. I'm in on that.
No, in a room full of DBHs and policy. I definitely can relate to that. Dr. Earl, Dr. Wright, thank you for taking time out of your very busy schedules to enlighten us and sharing your journey. And I just want to thank you for just simply making the time for us and, educating us in these special populations. Um, as DBHs, you know that our plight is, to find the gaps and fill them. And I thank you all for the work that you're doing out there, will do, and all the policy changes and different things that I know that will come in the forefront of your plight to improve healthcare for everyone. So again, thank you for coming out and share this time with me today.
You're welcome.
All
Yeah,
right.
Thank you for having us.
All right. And to our audience, thank you. Thank you for coming and sharing this moment with us. Please remember to like, share, and subscribe to our podcast. We bid you a good day. This podcast is brought to you by Cummings Graduate Institute for Behavioral Health Studies. CGI is celebrating 10 years of disrupting behavioral healthcare education to improve the way the world experiences healthcare.